situations in which we need to do the compensatory treatment, because when we do that, we apply the torque to compensate anterior and posterior, of course, but most important and most tricky part is to coordinate anterior segment, upper and lower arches. And when we do that in class 3 cases like this, to compensate, we need to focus on the possibility of doing the inclination. We go to the limit, up to the limit. So in some cases, we can't do that because we don't have enough bone. I will show to you one situation regarding to this condition. But when we can do that, the magic thing here is to find the correct position of upper anterior teeth in relation to lower anterior. And this compensatory movement in class 3 cases, they usually are not that bad, because when we do the torque, in opposition to what we saw in class 2 cases, we are not going forward, we're not throwing the root against the cortical plate. We are doing the opposite in the upper arch. We are putting the root inside the bone. I'm sorry, putting the root inside the bone. And because we are doing the torque in the root, mostly in the root. And look at this. This is a class 3 case with a compensatory inclination. And after surgery, you see that the correction of the inclination is very clear here. Because in this case, what we see is compensation and out of compensation. Because the correction of the inclination in class 3 cases for surgery is related to this. To remove the natural compensation, or sometimes the compensatory treatment that was done before. And when we do the correct inclination, we are changing the torque of upper and lower anterior teeth, and of course sometimes the posterior teeth, but this is mostly in the anterior segment, okay? And here we come to the prescription, Brecht prescription. Brecht's prescriptions are very used here in Brazil and in many parts in the world, because people want to, like, I would say, eliminate the need of thinking about orthodontic compensatory and torque situations in their lives. They want to change the way they think orthodontics, because it's easier in their minds to apply this concept, to apply just the prescription for class 2 or for class 3. But is it really something that we see in our daily practice? Sometimes it is when we have average cases, but sometimes it is not, because we don't just treat average cases. And this is the thing that will differentiate us from other orthodontists. We can treat everything. We can deal with the biomechanics. We understand the power of the diagnosis and treatment planning and the torque. Of course, this is probably the most difficult way of dealing with the biomechanics in our daily practice, because the torque is difficult to understand, is sometimes difficult to apply. You don't have this problem anymore because you have already seen how to do this the right way. But most of people that I know that can't deal with torque, they complain about this, the difficulties behind the torque. So they want to have something easier. And the prescription, the prescription come to our lives like this, to facilitate the way we deal with class 2 and class 3 cases. I'm not talking about standard prescription that we're going to see also, but about the class 2, mostly class 2 and class 3 cases, and what they do for us. Let's see. If I don't have a pre-programmed Brecht, meaning I have a non-programmed Brecht edgewise without inclination in offsets or angulation embedded in the base, embedded in the Brecht, we need to apply the torque since day one in orthodontics. We did that a long time ago. I do that sometimes when I want to compensate some class 3 cases. I'm going to show this to you. But most of the time, yes, I can use prescriptions for changing, for avoiding to do the torque since the beginning. It's time consuming to do the torque. For most people that I know, they don't practice torque that much, so they have these difficulties that are normal when we don't do this very often, in a very regular base. But what is going to happen if I don't apply a torque in a non-programmed bracket, like a well-positioned anterior upper set of teeth? What's going to happen to those teeth if I don't apply the torque? Because the teeth, they have the right inclination of the crown and the root also, and the angulation and inclination in edgewise brackets are zero. So if we have an inclination of the crowns, a good inclination of this crown, let's say this central incisor, and I don't apply the torque, what I'm going to have is a torque, a relative torque. You know that. A relative torque that is changing the inclination of the crown and the root towards palatal, root palatal, crown palatal, and root buccal. And in most of the cases, I don't want that. Especially in class 3 cases, I don't want that to happen. So I have the prescriptions to avoiding to do this since the beginning. So we're saving time in our daily practice, in our daily lives, because we can just insert the wire with neutral torque without the need of applying the torque, so we can keep or we can change the inclination towards the direction that I want. This is the general idea behind the torque, the prescriptions embedded in the brackets. What are the prescriptions that we see? 0 is the standard. 0 is the edgewise, non-programmed bracket, meaning we have the bottom of the slot parallel to the wall. The bottom of the slot, this wall here, is parallel to the base of the bracket. And if I have embedded prescription of inclination, I'll have this condition changed, like this, for example. If I have a different set of brackets with pre-programmed brackets, I'll have 3 degrees or 7 degrees. I can have many different inclinations. But when the inclination is the base, is something like that. We plan to position this slot parallel to the horizontal reference, to any or horizontal reference, like here. So we have this slot parallel to the horizontal line, and the base is inclined. We have the inclination of the base in relation to the slot, in relation to the bottom of the slot, the wall that is the vertical bottom, the vertical slot of the wall of the slot. I'm confusing now. The vertical slot and the vertical wall here. And we have the inclination in relation to the base. And the base still, if we want more inclination, is going to have further inclination in relation to this wall. So this is the prescription. Easy like that. The prescription in relation to inclination, of course, not angulation. The third key of Andrews is here. And it is good, of course it is, because it saves time. We don't need, since the beginning of the treatment, to apply the torque. Even when we have not a very good inclination of anterior teeth, we sometimes don't even need to apply the torque, because we have the clay inside the slot. We have some differences in inclination of the anterior teeth. So sometimes we just accept the inclination embedded in the slot. And this is for average case, this is good, because we can position the anterior teeth in relation to what we are planning. So I bought a class 3 prescription for this kind of patient. What's going to happen? I will treat average class 3 cases, because in average we have a good prescription that will be good for those cases for compensatory treatments. But let's think a little bit further about this concept here. Well, yes, it is good. We can avoid the need for doing this, because we know that in class 3 cases for compensatory treatment is different from class 1. because the inclinations are different. So in those cases, when we have, let's say, maxillary deficiency, a little bit of progenitic profile because of the maxilla, and also because of the mandible, it doesn't matter. We'll have, in this case, of course it matters because we're going to plan based on the diagnosis, but for now, I just want to focus on this, the condition of anterior teeth and the contact they have. So let's say we ran the sequence of arch wires and then we reach the rectangular one, and now we're going to insert the rectangular arch wire in this condition here. And I have a standard straight wire prescription. Roth or Andrews, they are very close in inclination in anterior segment. So we have here 7 degrees embedded in the slot, in the upper arch, and -1 degree in the lower. But the inclination of the crowns, they are very different from this. They are completely different because we have a compensatory inclination of both upper and lower teeth, anterior teeth. And if we are thinking absolutely, I'm not thinking about the play inside the slot, just for the sake of simplicity, let's say we have 22 degrees of inclination of upper teeth, and we have 7 degrees of inclination embedded in the slot. We have a difference of 15 degrees. Sometimes if we are inserting a thin rectangular arch wire, 1625, 1725, we won't change the inclination of an upper anterior teeth because we have the play inside the slot. And we know that for each 0.001 inch of difference between the height of the slot and the height of the wire, we have approximately 4 degrees of play. So a lot of play if we're using this combination. 22 slot, 16 wire, so we have a lot of play. This won't change. But if we insert 1925, things are going to be different because it won't cover the play. It will exceed the play, and it will apply a couple. And the couple here is going to change the inclination of anterior teeth. If we have a very compensated situation, especially in the lower arch, it is going to be very difficult for you. It's going to be very difficult for you to keep the compensation. And this is what is probably going to happen if you insert a very thick arch wire inside the slot. Filling almost completely the slot, you are having this situation. So you reached the rectangular arch wire and then you ruined your treatment because you didn't understand this condition, this combination, and you are going to decompensate your treatment. Is that what you want? Well, if it is, if you are doing this for preparation of the case for orthodontic surgery, it is good. But it's if you are trying to compensate, you're going to ruin your case. This is why you need to be aware of this. And what we need to do, let's talk about it. But let's see what's going to happen when we insert different brackets here. The brackets, the compensatory brackets, the class 2 or class 3 brackets, they are thought in two ways. They can be for finishing or for moving teeth in a compensatory way. Let's think about the finishing bracket, meaning I want to have a high inclination of upper anterior teeth, and I need a negative inclination, an extreme negative inclination to compensate lower teeth. What is going to happen now? So yes, I'm changing the bracket, so I don't need to think about it. Yes, it's a good thinking, but let's see some variables here. Well, if we have the finishing steps of our mechanics this situation, it will be probably good for you because you're keeping the inclination of upper and lower in average. Let's say 20 degrees or something like that in upper arch, minus 10, minus 15, I don't know what is the prescription that you're using, but it will keep the inclination. Not bad in this case, but if you have to compensate this bracket here that were thought for finishing, they will not help you. Let's say you want to apply a class 3 elastic. In this situation, the class 3 elastic will compensate the case by means of further inclination of upper teeth forward and lower teeth backwards, negative inclination of lower anterior teeth. And what's going on? Oh, well, we have the contact points here, and we are applying the force in the molar. I'm not thinking about here, in this case, about the oblique forces and the vertical forces, just thinking about the inclination of upper teeth, and because of that, I'm just focusing on this condition. So the contact points will reach the anterior segment, and then will incline anterior segment buccally. So we already have a good inclination, a steep inclination of upper teeth. The upper teeth, they are proclined to compensate this, and we are going to propose more inclination, which is very bad in some cases because we're ending up with a very strange, very odd anterior teeth inclination. And in the lower arch, same thing is going to happen. We are going to have a moment that is rotating lower teeth, and the view here, the sagittal view, is inclining lower anterior teeth further lingually in the crown. Okay, and this is also not very good in many cases. So the bracket that was intended for finishing may be not a good bracket for movement. So there is another thinking about it. There's a bracket that is thought for giving a good mechanics in sagittal way, in a sagittal way. So those brackets are different. They are upside down, let's say, almost upside down, because we have now a different torque for upper and a different torque for lower to compensate the moment of the force during the inclination, during the movement, the sagittal correction of anterior teeth. So the same situation here. Let's say what's going to happen when I apply this torque? The crowns, they are going to reach the inclination of the torque. Eventually, because we have a stiff arch wire, an elastic arch wire, that is changing the inclination of those anterior teeth. So this is what's going to happen. Of course, exaggerating a little bit here, but for you to understand the concept. What's going to happen now is I have a torque embedded in the bracket to compensate the moment of the force. So the moment of the force, we already know here, that is going to be in the upper arch a counterclockwise moment, and in the lower arch a clockwise moment. Also a counterclockwise moment, I'm sorry. But the bracket has the opposite, has the tendency of compensating this tendency of inclination. This is the way we think about the brackets, the prescriptions in a thought for compensatory treatment during the mechanics, not for the finishing phase of the mechanics. So now we have, in this case here, a torque in the upper arch that won't help me to finish, so I need to change the wire if I'm using this torque, and in the lower arch the same, because we know that those brackets are decompensating if we don't have the force. They're just compensating if you have the moment of the force. But since this moment is finished, we don't have it anymore, the brackets, they will do a very, they will position anterior teeth in a difficult situation for us to compensate, because they're giving the moment that we don't want. I hope I'm being clear here. So we have the moment of the force and the moment of the couple inside the slot. Even though we didn't apply the torque is already there, because the moment generated by the couple inside the slot is compensating for the moment of the force. So in this case, what I'm doing is thinking about the mechanics. But think about it. Do you have, for every case that you treat, do you have the same need, the same torque embedded inside the slot? I don't think so. So you must understand the concept of applying the torque by yourself so you can compensate individually. You compensate the inclination of upper and lower teeth in your own hand, in your bare hand. You're doing the torque for compensating because of that situation, that specific situation. So we need to apply this concept. And there's another problem here. The thinking that we have in mind when we do this torque is to do a moment, to apply a moment that will be counteracting the moment of the force. So trying to give the movement of the anterior teeth like this without inclination. But we don't have room for that. We don't have bone for that, distal to the crown, to the roots of the lower incisor especially. We don't have this. So what are we doing here? Are we putting the teeth outside of their housing, outside of the symphysis and the anterior segment of the maxilla? Is that what we want? If you pay attention, if you pay enough attention in some posts in the internet and Instagram, Facebook, you'll see that many people are applying this concept here, using TEDs in the lower arch and doing the retraction of lower teeth and using the hook, the high hook, the long hook. And the long hook is intended to eliminate the moment of the force. So if you're eliminating the moment of the force because you're applying the line of action at the same height of the center of resistance of the teeth that we are moving, if you're doing this, you're avoiding the inclination. Let's say applying 1925 in a 22 slot, and you're doing this using a high hook. You are eliminating the moment because you have zero distance or virtually zero distance between the line of action of the force and the center of resistance. So if you're doing this in a thin symphysis, you are going in a bodily translatory movement of anterior teeth to position your teeth outside of the bone. Well, I don't see the point here. So I think the best condition for applying the torque in a class 3 case is by allowing the inclination of teeth to take place. You don't do that using a resistant torque. You don't do that eliminating the moment of the force of retraction. This case is going to propose a translatory movement, not an inclination. So in this case, most of the cases that I see, because I see patients, hyperdivergent patients, they usually have the symphysis very, very thin. So we don't have enough space to go in a bodily translatory movement backwards or forwards. It doesn't matter. It's not possible. Yes, it is possible to move, but it's not possible to keep the roots inside the bone. And you don't want that to happen, I bet. So I don't believe in doing this way. I don't believe in just focusing on the right torque for that. I believe in individualization of the treatment. And you do that by means of applying the correct torque so you can have the correct movement or the most or the least problematic movement in some cases, because we are using this. Sometimes we know that part of the root is going outside of the bone, but if your patient, they have a good phenotype, a good periodontal phenotype, it will keep that position for life, okay? But if you're going extremely out of the bone, it will be a problem at some point. At some point, it will be a problem. So in this case, I prefer to use the concept of the passive torque to do the retraction or proclination, because the passive torque in this combination 30 slot and 25 22-25 wire, in this case I will keep a good movement, a good control during the inclination. I'm positioning the center of rotation of the movement closer to the apex, meaning I'm doing the inclination in a controlled manner, not uncontrolled manner. So I don't want the apex of the root to go forward or backwards in some situations, and I want to keep them in their position. The way to do that is, since the application of the bracket, since the first insertion of the bracket, I'm applying the right concept for that. If I'm doing just in the ending of my treatment more proclination of upper, more inclination of upper or lower, I need to understand the concept of the real and relative torque. And I need to balance the real and relative torque in order to apply this way of thinking, in order to have the right inclination. Okay? In a class 3 case, in the upper arch, usually applying a real positive ground torque. So this real positive ground torque, you've seen that before, is going to be applied using this concept of a very light force during the rolling of the wrist of anterior in anterior segment, so I can have the torque spread equally in the anterior segment. Okay, and this is the way I apply the torque. You know that we've seen that before, and you need to practice. Please do that. I told you the bad side of not knowing this. Like you're trying to do this, you need to do this, you know you need to do that, but you don't do this. What's going to happen? You are going to have a very long treatment, and it's not good for you and your patient. Okay, so practice this. Please do that for your career. And okay, and here it is. So when I insert the wire inside the slot, I will keep the position, and after that, because the first wire, the first rectangular wire, is just meant to align teeth, to refine the alignment. And after that, after the first wire, I can change this, like can give more or less torque, crown torque, so I can compensate for the right position of those teeth. And then, if I'm doing the retraction, I will apply the same concept that I applied in the class 2 case. I will have the resistant torque, but I don't like to do this in a class 3. In most cases of class 3, because it's meant to be done in the lower arch, and I just told you that we don't have enough bone for that. Resistant torque is meant to keep the inclination of those teeth during retraction or proclination. If I'm retracting lower teeth with a resistant torque, I'm keeping the inclination, and I don't have enough bone for giving this movement inside the symphysis. No way. So I prefer to use the controlled inclination to do that. So I don't use the resistant torque in the lower arch. And this is the same concept of applying a positive torque in the lower arch. A positive torque embedded in the bracket. I mean, if you have a positive torque for a class 3 case, for using elastics, for retracting, you are thinking the same way. You are trying to keep the inclination of those teeth. And this is not possible since we don't have enough space inside the symphysis. I don't want the bone to be there and the crown and the roots are going for distal or forward or mesial in this condition. I want to keep the apex inside the symphysis and change the inclination towards the position that I want to compensate for that type of malocclusion. So this is what I think about the class 3 prescriptions, because they are very difficult to control in the lower arch, okay? And then we need to do the retraction, or we need to do what we apply in this condition to correct the inclination. Let's see one case, and I'm gonna give you now another concept of how to treat a class 3 case. Class 3 cases, they are not horizontally treated. They are mostly vertically treated. When we do the correction of the class 3 by means of extrusion of posterior teeth, class 3 cases, class 3 elastics are going to do that. When you do the extrusion of posterior teeth, allowing for the rotation of the mandible down and backwards, we're correcting most of the problem. The class 3 sagittal problem will be corrected by means of this rotation. And I'm going to prove that to you. Well, let's see one case like this in which we don't have enough exposure of upper anterior teeth during smile. We know that in this condition of cephalometric analysis, we see that this patient, he has vertical deficiency, both vertical and sagittal deficiency of maxilla, and I want to correct this using the concept of the vertical displacement of the mandible. We know that McNamara told us that in his analysis that the triangle must be equilibrated, must be balanced, so we have a good position of maxilla, mandible, and lower anterior face height. When we change the lower anterior face height, not changing the size of the mandible and maxilla, we are changing the sagittal position of the mandible. We are changing the spatial positioning of the mandible. And it's going forward when we decrease the lower anterior face height. I'll look at the table, McNamara table, not changing the size of the maxilla and the mandible, just changing the height. We have, when we decrease, we have a relative prognathism, and when we do the opposite, we have a relative retrognatism. Okay, and we can change this in our treatment. We know how to do that. We have protocols for that. So we can change this without the need of doing sagittal movements, big sagittal movements that can compromise the treatment. And this case is going to show this protocol, this project of doing this. I want to extrude anterior teeth, to extrude posterior teeth. I want, of course, the maxilla to go forward, but it's not going to do like this in most of the cases as we want, just because we want. We have some restrictions for this, but the vertical is our friend. When the vertical can be increased, it is our friend. In this case, we did this type of treatment using class 3 elastics since day one, since bonding brackets, class 3 elastics. And here you see the inclination of upper and lower anterior teeth. And here we have the McNamara table showing that for that maxilla, okay, here we have it. Let's consider the mandible, a good mandible, and then for that maxilla, I could increase lower anterior face height. And I did that using elastics. Since day one, again, I'm telling you this, we have the extrusion of upper molars and rotation of the mandible down and backwards, which is very good for us. And this is going to control, this is going to decrease the need for doing distalization of lower arch, because the correction, most of the correction is going to take place in the rotation of the mandible. Mandible is going down and backwards, remember that. So vertical is our friend when we can increase the vertical component. Sometimes we can't, but when we can, it will help us a lot. And here we have the final step of our mechanics, and then the correction of the class 3. The most important part here is to see what happened to his face. Before treatment, we see the vertical displacement of the maxilla was not good. We have vertical deficiency, not showing the entire teeth of in upper segment, and we have this elastics being worn since the beginning. Why I'm focusing on since the beginning? Because we are applying those elastics in very thin arch wires that will not prevent the extrusion. And I don't want the extrusion to be prevented in this condition, because I want the extrusion to rotate the mandible down and backwards. And here we have it after a while. And then we have the end of the treatment. After some time after debonding, I didn't find the final photos of this patient. Probably I didn't take it. And here we have the comparison before, during, and after treatment. We see what's going on here. I'm concentrating. I'm doing the superimposition of some facial points, and you see that what happened here is increase in lower anterior face height. And increasing lower anterior face height helped me a lot to have the treatment, the compensatory treatment, with the rotation of the mandible down and backwards. It released removed from the system the need of doing too much inclination of upper and lower anterior teeth, because most of the correction took place because of the rotation of the mandible down and backwards. And comparing before and after, and the whole set of photographs, and the superimposition of the cephalometric x-rays. Before and after, and you see the rotation of the mandible and the vertical displacement of posterior and anterior teeth was what corrected the problem, not the real sagittal correction of the position of teeth. The rotation of the mandible was responsible for the correction of most of the sagittal problem. But this is something that we know since McNamara told us that we have this relationship between maxilla and mandible, and we can change this by using the vertical component. So I'm just basing my treatment on this topic, vertical component. Increasing or decreasing will help me in many, many situations, clinical situations, okay? And for finishing, let me show you a case in which we have the compensatory treatment was done before, good compensatory treatment in this patient. She had this class 3 relationship, maxillary deficiency, and also an asymmetry of the mandible. So we have maxillary deficiency, prognathism, a little bit of prognathism plus an asymmetry. And we wanted to decompensate. I just want for you to see the decompensation of it. The compensation that was done before was in order to compensate for the asymmetry, the lateral asymmetry, and also the anterior deficiency of maxilla and prognathism of the mandible. When we did the treatment for correcting this, when we did the treatment for removing the compensatory inclinations, what we see is this. Look, going forward with anterior teeth and changing the inclination, just using standard brackets for that. So standard brackets are meant to be used in class 2 and class 1 cases. Standard Roth or Andrews, they are meant to be used in class 1 cases. In this situation, a class 3 with asymmetry, just using the brackets, just using the prescription and thick arch wires, we managed to correct the inclination and prepare the case for orthognathic surgery. Look at this. So ready for surgery, and after surgery, removing the inclinations, removing the compensations, changing the torque, the finishing stage of the treatment. Also, torques are used for correcting inclination, for giving a good smile, and we do that in the final steps, okay? And here we have, after debonding, good inclination of upper and lower teeth, completely different from before treatment. Same thing here, just using standard standard straight wire brackets, and since they want class 2 in this case, because I'm preparing for orthognathic surgery, and our facial analysis showed us the importance of decompensating for orthognathic surgery. I'm just showing the example, I'm not focusing here on the theory behind that, because this is not a orthognathic surgery class, okay? And this is the compensation, and we are changing it by means of both brackets plus elastics. This is the natural compensation, and I'm removing it using the brackets, the straight wire, standard brackets plus elastics. Class 2 elastics in this case, because I want to decompensate. And the decompensation is going in the opposite direction of the compensation, of course. And this is what we usually do. We showed the compensation and now the decompensation in class 3 cases. Okay, and before surgery and after surgery, the correction of it. The negative overjet was correct in surgery. Pre-op, post-op, and you see that before treatment and after treatment, changing the inclination of upper teeth and lower teeth in the direction of the decompensation. So torques are very important in this strategy here, before treatment, during the compensation, and after treatment, after surgery. So guys, that's it. I wanted to show to you, since we know how to deal with class 2 cases, class 3 are very easy. The tips here are based on the correct way of thinking the prescription. Prescription may be good, but sometimes we need to understand what the prescription is giving to us. Is it a prescription for finishing treatment or a prescription for movement? And then we apply the concepts that we know of real and relative torque. And then we do the compensation or decompensation in relation to the individualization of the case. Here we have just a detail of a Z-band, second order Z-band, to provide enough room for doing the sagittal, for doing the osteotomy, okay? And here, after surgery, final steps of the compensation, decompensation, and here, before and after treatment. And that's it. For class 3, this is what I wanted to tell you. And in the next class, I'm going to show to you the relative torque in anterior open bite cases and biprotrusive cases. We'll see the importance of doing that this way. Individualization, okay? See you soon, guys. Bye-bye.